Good evening, everybody, and welcome to tonight's webinar, courtesy of Fujifilm and C.R.Kennedy. It's a wonderful thing actually to see everyone here tonight. There are about 240 people who have logged into this webinar, and I think it's a real credit to everyone's desire to continue education during COVID times. As you can see, for those of us in Melbourne, we can barely get out of the house, and I can't even get a haircut. But we're lucky enough to have two very esteemed international speakers, both Professor Neumann and Dr. Donati, and we'll introduce them a little bit later. My co-chair for this evening is William Tam, who I'll introduce in a moment, but well known to many of you. I'm Stephen Pianco. I'm the head of clinical trials at Monash Health and associate professor at Monash Uni, and an interventional endoscopist, as well as many other hats. So to lead in for tonight, I think we're lucky enough to hear about some of the new and up-and-coming things. And for some of it, particularly for myself, I've had the opportunity to use the current ELUXEO Fuji 7000 series, and there are a couple of new developments, and one has been LCI, that's link color imaging, and we'll talk a bit about that, and Professor Neumann's going to tell us about that. And really one of the biggest issues for tonight is the CAD artificial intelligence system. So there's no doubt that everybody's very interested in how we can continue to improve adenoma detection rates and who's going to be able to use these kind of new software and what advantages it has to experienced endoscopists and trainees alike, and recertification, and where this fits in with everyone. So, you know, you'll meet both Professor Neumann and Dr. Donati as we go, but in the first instance, you're going to hear from William Tam, who's going to talk to all of us. He's my co-chair for this evening. His association with Fuji goes back a fair way, doing his PhD when he looked at high magnification scopes for detection of reflux negative disease and Barrett's. He's had a lot of training in endoscopy both in Amsterdam, Tokyo and London, and he's the immediate past chair of the Faculty of Endoscopy and is a current director of the Gastro Society of Australia. And I'm going to hand over to you, Will, to give us some videos of what we can expect to hear about tonight and some of the changes we hope to get benefit from in endoscopy. Thanks, Will.
Thank you very much, Stephen, and a very warm welcome to our delegates. Some 240 of you have registered, and welcome you to this webinar from Australia. We know that we've got delegates coming from not only Australasia, but also Asia Pacific, Europe and North America. And it's certainly very exciting to be talking about artificial intelligence as a healthcare innovation in endoscopy. Now, my brief tonight is by way of introduction to just show a few short videos, which will highlight and show some of the key features of this system as used in clinical practice. So we'll have the first video. We'll play this video, and this first video shows the colonoscope in the terminal ileum, and you can see the zoom capability of this ELUXEO 7000, which has a magnification of about 175 times on a 32-inch monitor. And you can see here, not only can you see the blood vessels within the villi, you can also see the blood flow. So this obviously came from a patient without celiac disease. So you can see here a little bit of a mucosal prominence, and that when you turn on link color imaging, that there is accentuation of this mucosal prominence. And by using the zoom capability, you can start to see and appreciate the surface topography of this lesion, and you can start to see the pit pattern. And what I'd like to show you is, of course, the openings of these pits, which you can see under link color imaging. And this appearance is very typical of a sessile serrated polyp. Right there, you can see the little pits there. So the same polyp here is seen, we'll play the video, using blue light imaging. And you can see here under magnification, the whole surface is much better defined. You can see the pit pattern, you can see the absence of blood vessels. And again, you can see the openings of those pit patterns, very typical of a sessile serrated polyp. Now contrast that with another polyp. If you go to the next slide, this time we've got a smaller polyp. You can play the video, and You can see here white light. Now this is link color imaging. And now you will see it on blue light imaging. You can see the characteristics, the bruciform pattern of the pits and also the blood vessels around these crypts. And this is typical of a tubular adenoma. The very great pleasure of introducing our first international speaker, Professor Helmut Neumann, is well known internationally. He's a very well known international educator. He's professor of medicine and director of endoscopy at the Department of Internal Medicine at the University Medical Center Mainz in Germany. He's a therapeutic endoscopist and actively involved in clinical research in the areas of advanced endoscopic imaging, including computer-aided diagnosis and artificial intelligence. He conducts imaging symposiums and hands-on seminars around the world. Professor Neumann has published in over 160 articles and has recently been appointed chair of the new WEO. Congratulations, Professor Neumann. So without further ado, we'll lead into his talk.
Hi, this is Helmut Neumann from Germany. Thank you so much for having me with you. It's such a great pleasure giving this talk today about the highest adenoma detection rate with LCI and artificial intelligence. So, dear colleagues, what is the specific challenge at the moment in endoscopy? And I feel the specific challenge at the moment is still the detection of lesion and still the characterization of lesions. So in the past years, we have seen many developments of advanced endoscopic imaging modalities. However, still there is a question, what can we expect from those technologies? And I feel, first of all, we have to expect an increased detection and characterization, and first of all, by using different lights. And we all know about the traditional xenon light sources in the older endoscopes, and xenon light has only 3 different lights. So it has red, green, and blue light. But Fujifilm has introduced a couple of years ago already the so-called 4 LED multi-light technology. And very important with these 4 LED multi-light technology, we have still the traditional colors of the xenon endoscope, so red, green, and blue. But in addition, we have the so-called blue-violet light. And this is very important for us because for the first time, this LED technology allows us to use a specific mode, which is called LCI or link color imaging. And this is a very specific mode for us, for endoscopists, because it is changing the color of the tissue. However, only in this direction that the natural colors remain the same. So everything in the endoscopic image, what is red appears more reddish, and everything in the endoscopic image, what appears white appears more white. However, you can see, for example, that stool or residual components in the bowel, they still have the color. So blood is still red, although maybe a little bit more reddish, but red is red. And also stool has the normal color. So this mode is not interfering with the image interpretation. However, the question is it effective to use? And indeed it is. And therefore, we are considering this LCI mode now as a game changer. And it has been shown already in gastrointestinal endoscopy in 2017 that there is an increased detection of using LCI compared to traditional white light endoscopy. And this was a multi-center crossover prospective randomized controlled trial evaluating white light endoscopy versus LCI for the detection of colorectal polyps in over 150 patients. And as you can see, that with LCI, the overall polyp detection rate increased by 24%. 23% more patients with polyps were identified, and also of note, there was a significantly higher per patient adenoma detection rate. And also it has been shown in this recent publication in endoscopy, it was a randomized tandem colonoscopy study of LCI and the miss rates of neoplastic lesions in the right colon. You can see 600 patients were enrolled and randomized to one group. And first, the patient underwent colonoscopy with LCI followed by white light. The second group underwent first standard colonoscopy with white light followed by a second colonoscopy with LCI. But what we have learned from this study indeed is that the adenoma miss rate with LCI was significantly reduced compared to white light endoscopy. And I feel this is a very important parameter for us, and therefore we are now considering LCI indeed as a game-changing technology for us in endoscopy. However, the question is still, is it effective in the community practice? Is it effective to use advanced endoscopic imaging modalities in the community practice? And this publication in gastroenterology has addressed this question. You can see 13 gastroenterologists were trained for real-time optical biopsy of colonic polyps by using optical chromoendoscopy, but only 25% of the gastroenterologists assessed polyps with a greater than 90% accuracy. So the PV thresholds, as proposed by the American Society for Gastrointestinal Endoscopy, were not met. And therefore, I feel we have now the question, what can we do in order to make it more effective? What can we do? Shall we introduce a new light, or what is the answer? And now the answer is computers. And not only normal computers, but it's CAD. And CAD is the meaning for computer-assisted diagnosis. So we are using now artificial intelligence to help our patients and also to improve our diagnostic options. And in this context, Fujifilm has now introduced, as a first company in the world, a specific system allowing for both lesion detection and characterization of lesions as well. And you can see the system composition here in this system overview, and you can see that this computer-assisted diagnostic system of Fujifilm, which is called CAD-Eye, has a specific mode dedicated for colon polyp detection. It has a specific mode dedicated for colon polyp characterization, and also there is an integrated movie recording function as well. It's compatible with all scopes from the 700 series, and also I feel this is extremely important for us in endoscopy, that no additional monitor is required, but we can use the setup what we have already established now in our endoscopy rooms. So the operation is very simple by just using a scope switch as usual. So we just push the button on the endoscope and we switch from white light detection mode to LCI detection mode, and from this mode to the CAD-Eye BLI characterization mode. So just pushing the button on the handle of the scope and the mode is activated. Also, and this is very much in contrast to other systems allowing for detection of systems in real time at the moment, we have a specific graphic user interface of the detection mode. So you can see, first of all, we are seeing if the mode is enabled or disabled. But most important, we have also a detection box displaying the area where the polyp is thought to be detected by the system. And most important also, there is a detection sound. So we can indeed hear a beep when the system is detecting a polyp. And this beep is extremely helpful because I will show you later the false positive rate of the system is extremely low, but the computer is sometimes so fast that the polyp is detected only by the computer, but not by our human eyes, and therefore the beep sound is extremely helpful for us. And also, and this is a major difference to all the other systems on the market, we have also a so-called visual assist circle lighting up in the direction where the polyp is detected. So we all know the problem that we are finding a polyp and then suddenly it's gone. This system helps us to identify the direction of the polyp by highlighting in which direction of the image the polyp is detected. So if it's more here in between 12 or 3 o'clock, between 3 or 6 o'clock, between the position of 6 and 9 o'clock, or between 9 and 12 o'clock position. And I want to show you the endoscopic image here of the CAD-Eye real-time detection. And you can see this image is now showing in the retroflex mode of the endoscope. And you can see there is a lot of debris and stool left, but the system is only showing the polyp here. And you can also here the detection sound, and also you can see the detection box here. And at the moment we have no visual assist circle because the lesion is detected in the central part of the endoscopic image. But again, I feel of note to highlight that all the residual components are not highlighted as polyps here. Another example of the cat eye detection mode here of Fujifilm, what you can see here, we have here now the LCI mode enabled, and again you can see a very flat lesion highlighted here in the image, and also you can see the detection box which is highlighting that there is indeed a polyp. You might argue those are not very difficult lesions. So what about more difficult lesions? Again, this is now in the ascending colon. We can see the ileocecal valve here in the back, and we are withdrawing this, the endoscope. And we all know that there is a flexure, and sometimes the passage of this flexure is very fast, and we might miss lesion in the right colon, as we all know. And please have a look what the system is detecting here. So we can immediately hear the sound. We go back and there is a large polyp. But I feel although this polyp is a large one, it might be relatively easy being missed because it's directly located behind the next fold. And even when the bowel preparation might be not that well, or if it's maybe a procedure in the afternoon, or even maybe performed by someone who is not that much experienced, although this lesion is very big, it can be relatively easy being missed. However, not with a cat eye. This is also a very exciting example because what you can see here, you already have heard the sound. The system is also very valuable in detecting sessile serrated lesions. And what I've learned that specifically those sessile serrated lesions are very common in Australia. And of course, we know that there is increased risk even of developing colorectal cancer, but you can see the system also works in identifying this typical sessile serrated lesion. And also another question is, what about residual neoplasia after colonic EMR? And also you can see that there is a typical EMR scar, and you can see that there is a little bit of residual neoplastic tissue, and very exciting that the cat eye also allows us to detect the residual tissue in real time. And also what is currently evaluated in studies is to do this evaluation directly after endoscopic resection in order to avoid residual neoplasia after endoscopic resection. Is it now effective to use cat eye, yes or not? And our group has evaluated this artificial intelligence in combination with link color imaging for detection of colorectal polyps, including sessile serrated lesions. And you can see that the cat eye with LCI was first trained for colorectal polyp detection. And then we had a validation set of 240 polyps. But most important, you can see the results. And the true positive rate per lesion, so the sensitivity in this study was 100%. So indeed, no lesion in this study has been missed. The calculated false positive frame rate was less than 0.0%. So very, very few false positive cases. And I feel this is also very important when we're using such a technology, because we want to become more effective, and the technology should help us in order to become more effective and not take our time. And lastly, also what I've shown you in the video presentation already, LCI with a cat eye also detected all of the sessile serrated lesions in the study. So none of the typical sessile serrated adenomas were missed. So yeah, chairperson and ladies and gentlemen, in conclusion, I think we have seen that the Lely Fujifilm cat eye allows for detection and characterization of lesions, and also is approved for use specifically now even in Europe. So for example, in our center, we're using the system now in the routine daily clinical practice. LCI cat eye achieved a 100% sensitivity per lesion and a negligible false positive frame rate. And also, I feel it's extremely important for us to highlight that the detection rate for sessile serrated lesions by using LCI cat eye was also 100%. So the future is here, and we have to welcome artificial intelligence and the cat eye. Thank you very much.
Helmut, thank you very much for an excellent talk, and I think a very interesting insight into some new developments. I wanted to start with LCI a little bit with you before we get into the CAD. And so I changed my practice in the last 8 months, and I've been using LCI, and I was quite surprised, in fact, that the benefit I was getting in adenoma detection and really characterization to be able to identify polyps. So it's led me to the extent that I don't withdraw on white light now. My preference for withdrawal is LCI light, and I'm interested to see in Europe what's the preference. Do you come out with white light, go back, come back with LCI? What do you actually do as a preferential withdrawal technique?
Yeah, thank you very much for your question, and thanks again for having me with you. So good morning from Germany. It's 11:22 now in Germany, and I always enjoyed so much with you in Australia. Unfortunately, we're not able to see each other now in person, but at least online. So first of all, thank you very much. And we do the same, what you have described. So we go to the CECM by using the standard white light endoscopy, and on the way back, we switch definitely to LCI, to linked color imaging. We prefer this because indeed we have learned from the studies that the adenoma detection rate is indeed significantly increased by using LCI. And of course, we want to serve our patients and we want to do the best job possible. And therefore, on the way back also, we always use the LCI mode.
Can I just ask you on that front? I don't know if you can hear me, but can I ask, did you notice for yourself that it even improved your adenoma detection rate and your visibility? I mean, you're a very experienced endoscopist with, I assume, a good adenoma detection rate. And what did it do to your serrated polyp detection rate?
Yeah, so definitely, I feel it is improving my own detection rate as well. And your question is so important because it covers the other important question. Do we really need always new technologies in endoscopy? Is it necessary to develop new technologies? And I feel it is, because we know about the miss rates. We are missing lesions, specifically what you have also addressed. The cess-ulcerated lesions might be relatively easy being missed. But therefore, we need the new technologies. And if you're asking me directly, if I feel that LCI is improving my individual adenoma detection rate, I would answer definitely yes.
I'll hand over to Will with his questions.
Thank you, Helmut. What a marvelous presentation, very captivating, and I think that you know this new technology. I think essentially has the ability to improve ADRs in someone who's experience. Do you think that the AI, the CAD technology is more important or more useful in training versus people, young consultants? How would you recommend its inscription in a training program?
Oh, well, thank you so much. That's such an important question. If I feel that technology CAD-eye is only helpful for experts or non-experts, and I would say it is definitely even helpful for the experts. And we are all discussing the adenoma miss rates. And we all know that this is at least the polyp miss rate, at least 30%, but we should not forget from whom we have learned the data. And Doug Rex has published this data a couple of years ago, and I feel Doug Rex is definitely one of the most experienced endoscopists in the world, and he has published that at least 30% of polyps can be missed in his tandem colonoscopy study. So definitely we are all missing lesions, and even if we're very experienced, there is a risk of missing lesions, and therefore I have no doubts that indeed by using CAD-eye we will become much more better, and definitely this is what we have to do as well.
So Helmut, along those lines, in Australia we now have recertification for colonoscopy. So you have to achieve 25% adenoma detection rate, and you have to achieve roughly 4, and that number will go up, % serrated adenoma detection rate. So one of the things that's coming up is how do we retrain the people who aren't meeting criteria? So do you think this, you know, the artificial intelligence you're showing us can actually help an experienced colonoscopist who might not be getting there and might not be seeing the serrated adenomas they need to actually improve their own, you know, skills to now get recertified and achieve their targets?
Oh, that's a very exciting question. I strongly believe that indeed by using artificial intelligence, specifically here the Fujifilm CAD eye, we can even improve the situation massively. And this is also what we have learned from the recent study, that the CAD eye is not only helpful for detection of the of the traditional adenomas. So we're not only detecting more tubular adenomas, but it's specifically helpful for detection of sessile serrated lesions. And again, I want to highlight that in this study, I've shown you none of the sessile serrated lesions have been missed. So this was a preliminary results. In the meanwhile, more than 800 patients have been included in this study. And again, so it's so exciting that the CAD eye machine is really helping us to detect the sessile serrated lesions. And again, I feel we have to acknowledge the system is much more faster than the human eyes. So we all know that even, we have the old studies, we can increase our adenoma detection rate when the nurse is evaluating the endoscopic images as well. So a non-trained endoscopist, the nurse is a non-trained endoscopist, but only also when the non-trained endoscopist, namely the nurse, is looking at the endoscopic image as well, we're detecting more lesions, and significantly more lesions, because 4 eyes are seeing more than only 2. But we can imagine that by using artificial intelligence, a system which is more than 18 times much more faster than the human eye, of course, is dramatically helping us to improve our detection rate. And also, again, I would say for the experienced users.
Well, thank you very much, and thank you for a wonderful talk. And from my own experience, I certainly think for particularly the serrated lesions, it offers real advances, and I think that AI will hopefully take that a step further. Now, I'd like to introduce Manuel Rondinotti from Como in Italy, from the Ospedale Valduce in Como. He's kindly agreed to give up his time this year. I think for those of you who realise where Emmanuel works, he's been in the heart of the epicenter of COVID-19 and suffered like suffered like many. I'm getting a mute sign, but I'm not muted. Can you hear me? Yeah. So he's been actively involved and provided hands-on seminars in a variety of research, including capsule endoscopy, BLI, and recently CAD eye. Published over 100 articles in gastroenterology with over 1,500 citations. It's a real pleasure to welcome you to Australia. As we were discussing before, you're as close to me as the people listening tonight in the other states of Australia, because I'm locked up here and not allowed out of Victoria. So wonderful to see you. And I may get to Italy before I get to South Australia or Queensland. So nice to hear from you.
Dear colleagues, first of all, I would like to thank you for giving me the opportunity to be here with you today, even if we are together only virtually because of pandemic. I would like also to thank Fujifilm for the kind invitation to be here today. My presentation will be about polyp characterization from BLI to artificial intelligence. Why are we talking about this topic today? Because as we know, the number of polyps detected during colonoscopy is steadily increasing, and the majority of polyps we are identifying are diminutive or even small, as demonstrated in many studies. And we also know that there are costs related to removal and histopathology evaluation of those polyps. It has been already demonstrated since more than 10 years right now that if we are able to apply a resect and discard strategy in clinical practice, we are able to save money. But before implementing any kind of resect and discard strategy, we have to be able first to correctly and reliably predict the histology of those polyps. Only if we are able to do that, we can decide how to manage those polyps. How we can do that? We can do that in several ways, but we know that the best light we have to use for doing this kind of task is the blue light, because the blue light of 410 nanometers is selectively absorbed by vessels. And when absorbed by vessels, is emphasizing the surface features of polyps. We can recognize vessels, we can recognize the shape, the size of crypts, the position of those crypts, presence of depression also, and all those features are crucial for polyp characterization. In addition, the BLI system is using a LED illumination or a laser illumination In both of those cases, images we have are very, very bright, so they are quite easy to be evaluated. This is an example of the same polyp seen under HD white light and under BLI. But as we know, things are changing. I mean, there is something new appearing into clinical practice right now, which is basically artificial intelligence, which is able to do the same kind of task just by pushing a button, just by activating an algorithm. As far as I know, the CAD module from Fujifilm is the only one available in the market, able to perform at the same time both characterization and also detection, as already shown before. When we use this system, we are facing with a polyp like this one, for example, which is a diminutive adenoma. As soon as we are activating both the CAD system and also the BLI, of course, which is the light we have to use for characterization, there is a small screen appearing within the main screen you have in front of you, so no additional screens are needed. This small screen in the right lower quadrant of your image is a location map. Within this location map, there is a dot, with a colored dot, which corresponds exactly to the position of the polyp in your main screen. This is extremely important to know because it means that we and the machine are focusing exactly on the same area. So that's the polyp we are characterizing. It's extremely important to know that, because only doing that, only checking continuously if there is a perfect correspondence between those 2 points, we are sure that we are focusing on the same area. Together with this dot, which is colored in yellow, the dot could be yellow or green. It is yellow when the outcome from the machine is for a neoplastic polyp. It is green when the outcome from the machine is for a hyperplastic polyp. Together with this dot colored in yellow, there are also those 2 brackets, yellow too, and those brackets are giving us the same kind of information of this dot. So we are facing with an adenomatous polyp. There is also a written banner over there, which is confirming the information provided by the color. So we are facing a neoplastic lesion. There is another point I would like to highlight you before going over with other images, is that there is this bar, which is gray and is made by 3 segments. This is extremely important bar because it's providing us a very technical and crucial information for polyp characterization, because before being able to provide a real reliable characterization, the system has to acquire a lot of information. And only when all the 3 bars are fully colored, only when the 3 segments are gray and stably gray, it means that the system is already acquired all the information needed for providing a reliable polyp characterization. I hope that those video will be probably much more explanatory than my previous slide. So here we are. There is a polyp, which is a diminutive polyp, as you can see, a diminutive adenoma. We can activate by pushing a button the CAD system for characterization. As you can see, the bar here is going up and down, and you can rely on characterization only when all those 3 bars are together gray. And when all of them are together gray, as you can see, there is also a stable signal, which means that this polyp, which is in the same position of the main screen, the dot corresponds to the main position on the main screen, we are facing with an adenomatous polyp. Another example here, this is an hyperplastic polyp for sure. We can decide that by looking with BLI without CAD, but as soon as we are activating the CAD, as you can see in the next few images, we have immediately an output. In this case, the output is green. It means that we are facing an hyperplastic polyp. As before, all the 3 bars are gray and the main dot and the brackets are green. We have to remember that we are dealing with images. So we have to remove every single debris between the tip of the endoscope and the surface of the polyp. Everything located between the tip of the endoscope and the surface of the polyp can create some distortion in the light. And since we are focusing on features of this polyp, we can miss some relevant features. The system can miss some relevant features, and that therefore it cannot provide a reliable characterization. So we have to use water for removing any debris, but at the same time, please remember that going underwater, the characterization tends to turn to hyperplastic. So please remove any excess of water from inside your lumen. This is extremely important. We don't have any obvious explanation for this phenomenon, but probably the liquid, the fluid inside the lumen is not always clean. There are some small debris, and those debris can create some sort of blurry effect. That blurry effect can impact on the capability of the system in characterizing the polyp. We have also to remember to keep the polyp in a frontal view in the center of our screen. Last but not least, there are also some settings to be settled in your machine. So please ask your Fujifilm staff to check if you are using the best BLI setting for polyp characterization.
Emmanuel, thank you very much for really a wonderful talk. You said that you've been using it for a few months. I want to know what impact this has had on your practice. Are you really using the characterization, or is it still, you know, a bit of a pipe dream?
What I can say by using the system from months right now is that by using AI combined by my own evaluation, the process is generally quicker. You can save time, and also that the number of polyps you are evaluating with high confidence, if you are using also AI, is quite increasing. Because sometimes when you have doubts and you check the polyp with your own eyes, you make your own prediction and then you activate AI. If AI is confirming what you already evaluated at the beginning, you are having a sort of confirmation. And so the number of polyps you initially evaluated with low confidence is decreasing, is dramatically decreasing. So if we are seeing what's happening in the near future with those kind of systems, we can expect that it will be even much more contributable for both experts and non-experts.
Helmut, just touching on that, well, you've obviously experienced the characterization stuff as well. You know, what experience have you had in terms of characterization of the lesions?
Yeah, thank you. So we're using the CAD characterization mode now since more than 7 months, and our experience is really fantastic. So very obvious is that the system is able to identify the polyp even on a very long distance, you know. So when we want to characterize a lesion, we all know we have to go very close. We need a very clean surface. It takes some time to wash the lesion, to clean the surface in order to gain a good interpretation. Excitingly, this seems to be not the case for CAD characterization. So you have to imagine you're in the transverse colon, and in the far away you are seeing a small polyp, and then you're switching to BLI characterization, and then the system already shows you if this is a neoplastic or a non-neoplastic lesion. Excitingly, it also works when there is a lot of stool components in the endoscopic image. So definitely our experience is very good. And what we are doing in Germany, we are also doing a study where we are giving the system to private physicians. So it's really to some colleagues who have no experience in doing studies, but who are only doing screening colonoscopy every day. And they like and appreciate the system very much because it's increasing the confidence very much. And there was a question from the audience if we feel that CAD is increasing or decreasing the time of colonoscopy. And I feel this is one of the most important questions for all of us, is it? Because we need a technology which is helping us to become more effective, and not a technology which is taking our time. But in the very preliminary analysis, we're seeing that colonoscopy becomes more faster, but more important, even the confidence level of the endoscopies is increasing because artificial intelligence is really very helpful in our practice.
Era of AI-assisted endoscopy is well and truly upon us, and we're going to see a revolution of this change our clinical practice. So thank you both, our international faculty, very much for sharing your insights with us. I want to thank all the delegates who have tuned in to join our webinar. I'd like to thank Fujifilm and C.R.Kennedy. I'd like to just mention that CAD is officially launched today. So those of you who are interested in the system, please contact the C.R.Kennedy territory manager for more information and possibly a demonstration. So my final thought is to thank everybody for a very successful webinar. Thank you, Stephen, for my co-chair for a wonderful discussion. And thank you all for joining us this evening.